Good morning. My name is Monica Busse, and on behalf of myself and Lori Quinn, who were the chief investigators for the Physibility trial, we'd like to thank the organisers for inviting us here to talk to you about the results from the Physibility study. So Physibility is a trial that set out to evaluate a long-term physical therapist-led physical activity intervention to promote physical activity in Huntington's disease. It was funded by the Jack and Gloria Gosweiler Foundation. So what do we know about physical activity in Huntington's disease? Well, we know physical exercise and activity are important in the management of disease-related symptoms and in preventing functional decline in people with HD. We have evidence for shorter-term interventions lasting up to 16 weeks, and we've also got evidence for longer-term, lasting sort of 9 to 12 months, complex multidisciplinary interventions which may combine physical, occupational, and speech therapy as well as cognitive training and sleep hygiene interventions. But one of the challenges in physical activity interventions and the multidisciplinary interventions is that they are complex interventions. And what we don't have is evidence for longer-term physical activity interventions per se. So we set out to evaluate longer-term physical activity interventions where we were clearly defining the physical activity components of that intervention. And we did that through a trial within cohort study. One of the reasons why we chose a trial within cohort design was that it's very challenging to evaluate lifestyle interventions. And where we have the facilities of long-term cohort studies, such as Enroll HD, we wanted to know whether it was possible to run a trial within a cohort such as Enroll HD, because we felt that that would be the way to inform designs in the future where we could be opportunistically using this kind of data to provide ongoing evidence to evaluate multidisciplinary or physical activity type interventions. So we needed to establish the feasibility of a trial like this, and we ran this as a multi-center trial where we had sites in Europe and the US, and we were doing a prospective assessment of physical activity and fitness, because these were assessments that were not typically included in the Enroll HD annual assessment. And we recruited 120 participants to the trial. 60 of those were in the reference cohort, and then 60 of those were in the randomized controlled trial. So all of them had a 12-month follow-up, but in the randomized controlled trial group, there was an additional 6-month interim assessment. So the intervention was a coaching intervention, and that coaching intervention was delivered face-to-face with over a period of 12 months. There was a supportive workbook, a disease-specific workbook. There was the option for equipment or funding to attend gyms or fitness centers, and then we used activity trackers. The underpinning theory of the intervention was based on self-determination theory. So within that theory, we were promoting autonomy through giving the freedom of choice. We were promoting competence by encouraging goal setting and self-efficacy, and developing specific skills for physical activity. And we were encouraging relatedness. So there was a shared sense of experience, and that we were listening and responsive to the individual's personal preferences. And these are all components of behavior change interventions that are considered to be important in long-term physical activity uptake. So we included anybody with a genetic diagnosis of Huntington's disease who was over the age of 18 and were enrolled as a participant in Enroll HD. We also required for individuals to be up to or including stage 2 disease status. So this was a total functional capacity of between 7 and 13. We didn't include individuals who had juvenile onset HD or any other comorbid neurological conditions or acute orthopedic conditions. And all participants were required to give written informed consent. So in terms of the feasibility, we wanted to know whether we could recruit participants, whether we could retain them in this trial, which involved physical activity assessments alongside Enroll HD assessments, but also there was a group of individuals who were offered an intervention, and we wanted to know whether people could adhere to that intervention. We wanted to know whether the intervention could be delivered in the way it was intended, which is what we call fidelity, and we wanted to know whether it was safe. In terms of the trial linkage, we were then interested in data completeness. In terms of the clinical outcomes, we assessed fitness, physical activity and walking endurance, we assessed patient-reported outcomes, and then we linked our outcomes to the Enroll HD core and extended batteries. So of the 116 participants that we enrolled, so we achieved 98.3% of our recruitment target. We randomized individuals within the randomized control arm, and we also then allocated individuals to the observational cohort. We had 53 participants start within the randomized control arm and 59 in the cohort. Our retention was in the region of 80% for the RCT and slightly higher for the cohort. In terms of the baseline demographics, the groups were relatively similar at baseline. We looked at medications, and if we looked at the groups in terms of their gender, their age, their body mass index, and their CAG repeat lengths, they really were relatively comparable to at baseline. In terms of feasibility, our data completion at baseline ranged from 42 to 100% for the cohort and 88 to 100% for the RCT. So it's important to point out, though, that this data completion was the extended battery as well as the core battery for Enroll HD. And at baseline, 93.8% of our individuals completed all or part of the PACE HD assessments within 6 weeks of the Enroll HD assessments. And at follow-up, 69 out of 95 were within the required windows. In terms of safety, we measured falls, or we assessed falls, and we had 42 falls reported by 27 participants in the control group and 43 by 26 participants in the intervention group in the trial. There were 8 recurrent fallers, which we defined as being more than one fall over the period in the control group, and 6 in the intervention group. And 2 control participants attended hospital emergency rooms as a result of falls, but didn't require admissions. And we had no serious adverse events reported in either of the groups. In terms of the feasibility of the intervention, 80%, around 80% of the maximum possible sessions were attended by participants. So on average, participants had 14 sessions over the 12 months, whereas they could have had 18. In terms of the activity monitors, so the participants wore Fitbits, and heart rate on the Fitbits was detected on 269 of, on average, 364 days. So on 75% of days, we were able to confirm that heart rate was detected, which meant that individuals were wearing those Fitbits. 19 out of 23 individuals had more than 70% of the days where they met the 10-hour wear time criteria. So that was where we defined what is valid wear time for wearing an activity tracker. And all the intervention checklists that we utilized confirmed that the intervention was delivered as we had intended it to be delivered. So when we look at the effect estimates, so the differences amongst all the groups, and we looked particularly at fitness, what you can see in this table here is you can see the data for the cohort group at baseline and at 12 months. And then you can see the data for those who were in the randomized controlled trial group, and that was again between control and intervention, and at baseline and a 12-month follow-up. And then we can see what we call the differences, so the 95% confidence intervals for the differences in the randomized control group. So this study was not powered to be looking for effectiveness, but what we can see if we look at the 95% confidence intervals for the difference in terms of fitness is that those individuals in the intervention group were fitter, on the whole, were generally fitter than those in the randomized control usual care group. And they also walked slightly further. So when we look at those confidence intervals, we can see the tendency towards improvements in those two measures. What was also interesting for us is that in the cohort group, we noticed that actually we could see from baseline to 12-month follow-up. So if you look at the fitness values, we can see that actually there was a reduction in fitness from which was a bigger reduction than what we saw in the control group. So we were interested in that finding and also in the same pattern that we saw in terms of distance walked. If we look at the other data in terms of self-reported disease symptoms and in physical activity, what we can see again is a trend towards increased physical activity over the 12 months in the intervention group. So in summary, what does this mean for us in terms of the feasibility and the design? Well, what we know is that it's possible to run a long-term evaluation of a physical activity intervention in individuals with HD, and we've managed to do that. We were able to successfully recruit 116 individuals with HD across 3 countries at 6 different sites. The intervention, which was delivered over 18 sessions over 12 months, was safe, and it was associated with some benefits in terms of fitness in early to mid-stage HD. So individuals in the cohort who received no contact or intervention over the 12-month period that we were involved in seemed to decline at rates that was comparable to what has been previously reported. But those in the control group didn't seem to decline as much as we could have expected. So that's in terms of the fitness and the physical activity measures, the walking distance as well. And we wondered whether that's the influence of being in a clinical study where they know that they were being studied in terms of their physical activity and whether that influenced what we were seeing there. We were able to meet the pre-specified criteria for minimum data set completion. That was for PACE HD and the linked Enroll HD data sets. And so we can confirm that linkage to Enroll HD is feasible, and it has utility for long-term physical activity evaluation in Huntington's disease. So what does this mean for the HD community? So PACE HD provides an exemplar of a structured protocol with an intervention approach that's grounded in behavior change theory. So the intervention is underpinned by self-determination theory, where we're encouraging autonomy, relatedness, and competence. We needed to do quite intensive intervention training to make sure that the intervention was delivered as we wanted it. We supervised remotely across all the sites. We were trying to get consistent coaching conversations that were happening at all the sites. We needed to train staff on how they could support HD participants to use the activity trackers for their own goal setting. And so that was a critical kind of aspect of the work that we did in terms of standardization. But what that means is that if we've been able to show that this is a structured protocol with an intervention that can be rolled out with some training, and it is feasible and it is safe, and there is some indication of benefit, is that really what we should be moving towards are consultative models of care, where there is support for long-term physical therapist-led physical activity. And this should be something that really is routine in HD clinical care. We're seeing this much more in various other diseases where there are recommendations for this regular physical activity type intervention, where the relationships are built up very early on in the disease life cycle, and there are then episodes of intervention as is needed. And we've shown now that it is possible to deliver such an intervention, but also that it would be possible to utilize a cohort study like Enroll HD to provide ongoing evaluation. So just to finish off then, I'd like to acknowledge the PACE HD study team who have worked tirelessly with us across all aspects of the study for us to be able to deliver the study. And I'd like to also acknowledge all the PACE HD and Enroll HD site principal investigators, without whom this study would not have been possible. And also to say that the Enroll HD team and their incredible work in helping us achieve the data linkage that we did. So I'd like to thank everybody very much for that. And my colleague Lori Quinn is going to be able to be with us now to take any live questions and give some answers. Thank you very much.
Hi, how are you? Thank you very much. It's really great to be here and to be able to continue on with the Q&A from Monica's presentation about the PACE HD study. I'm going to start off with a question that came into the chat. Can you explain why a trial within cohort was a design of choice, and what are the pros and cons of such a design for future HD trials? So as Monica mentioned, we really wanted to see if we could implement this within the current Enroll study. And we felt that it would be important to try to see if we could implement this in such a way that it could eventually be that we wouldn't have to do a randomized control trial. Randomized control trials are, as everyone probably knows how difficult they are, and especially within physical activity and exercise intervention. There's also a lot of competition with many of the trials that are going on right now, and we certainly recognize that exercise and physical therapy may not rise to the top of the priority list when there are drugs that could be, or interventions that could be disease modifying. But we do feel that exercise and physical activity has a really important role with people who are living with the disease, and we want to try to find a way that we can have high quality studies that will be able to demonstrate this. So we think it was really interesting the way that the cohort group, and Monica sort of went through this, the cohort group really declined as we would typically expect, in line with previous studies over 12 months of the changes that we saw in the cohort group. And they got absolutely no intervention. So they were measured at baseline and they were measured at 12 months later, and they declined in many of the aspects, the total motor score, on the 6-minute walk test, all of our functional measures, as we might expect. But those who were just in the RCT in and of themselves, certainly in the intervention group, we showed those improvements in some of those functional measures. But what was also interesting was what happened to the control group. And the control group, actually, just by being in the RCT, because they were questioned every month to determine what their exercise level was and whether they had fallen, just having that regular contact and also having a 6-month follow-up seems to have done something, because those individuals actually seem to stabilize a bit. Now, Monica, I think, went through very clearly that we were not powered for efficacy. We were really trying to see where the trends might lie. And certainly they lied in the places that we emphasized with the intervention, which was great. So it may be that in the future we could use completely a cohort study like Enroll and drop in an intervention if we're able to match up the cohort with the people who are in the intervention. So we're really hopeful that we can use this type of a trial design and possibly be able to run this kind of a study alongside other intervention studies, although I know that there's issues with that. The second question that came in is the HD Pro Triad total score is from the HDQ Life. That was a question. And were any other patient-reported outcomes collected? I don't think that the HD Pro Triad is from the HDQ Life, but I could be wrong on that. It is, the reference that we have for that was from a study from Noel Carlozzi in 2014. And so it's a patient-reported outcome measure. And as you saw, there was no differences in the groups. There was no indication of improvement. We did also look at the SF-12. That is part of the Enroll battery. We actually had, there was a bit of a trend for the physical component of the SF-12, but we actually had pretty poor completion rates for that for sort of some unknown reasons. But that, I think because some of the batteries were part of the extended battery, or I think some of the sites may have just not done some of the assessments for various reasons. So that was one of the measures that we didn't have quite as good of completion rates for. But patient-reported outcome measures are really important for certain. And, the physical activity questionnaires are patient-reported. They're about how much activity people do, but they're not about sort of quality of life measures. Another question that comes in is, can you give more details about the intervention design and implementation, and why are theoretical behavior change theories relevant? So this is an interesting point. I think for physical therapists, we typically think of PT as coming in and doing, physical sort of hands-on work, and you're helping people, you're doing balance exercises, helping them with fall prevention. But more recently, and we think that this is a really important area, physical therapists have been focusing on physical activity uptake. We recognize that there's sort of this disconnect between having patients come in and doing exercises in a clinic with us, and then we send them off to home and they're not engaging in exercise, and they might be leading relatively sedentary behaviors. That really counteracts any beneficial effects of being in physical therapy. So what needs to be done is, in combination with potentially, in-person episodes of care, is working with individuals to try to get them to have increased exercise and physical activity uptake in the home. We also think that this is important from the very earliest stages of the disease. So right at diagnosis, and I would certainly argue at the prodromal or pre-manifest stages, really emphasizing the importance of exercise. I think we've had quite a few studies now to demonstrate the benefits of exercise, certainly in many other neurodegenerative diseases. And we have, some supporting evidence in Huntington's about how important that is. So, but the behavior change piece is really important because many people, even very early on, are leading more sedentary lifestyles. And certainly not everyone, but when you have someone who's leading a relatively sedentary lifestyle, it's not just a matter of telling them you should exercise. That is certainly a great first step, and I would encourage all the neurologists and nurses who are listening to really talk about exercise and activity from the beginning. But what we know is that education and health literacy alone is not enough, that they need support and help to be able to implement this within their lifestyle. They need the autonomy to make choices about what exercises they would like to do and that are relevant to them within their lifestyle, things that they might have done, and using specific behavior change techniques, things like motivational interviewing, things like using goal setting. are, I think, essential to get that long-term lasting behavior change and really get that implementation throughout the disease process. We also know that the earlier we implement this, the more likely it is that they're going to be able to implement it throughout the course of the disease, because one of the things that we start to run up against even relatively early on is apathy. And that's something that we really need to think about. And we do think that we are able to overcome this with a program like Physibility. Okay, let's see what else we have here. The primary outcomes were acceptability and feasibility. Were there any positive signals for health-related quality of life or other markers of symptom reduction? The answer to that is no. So to the second part of the question, so primary outcomes were acceptability and feasibility. Yes, absolutely. So we wanted to show, was this an intervention that was acceptable? So this was a relatively unique design, even within physical therapy, to have an intervention. In traditional physical therapy studies, like in Parkinson's disease, you don't really see an intervention like this. We wanted to see, okay, this is a long-term degenerative disease. It's not really great that we would be seeing people for sort of these short episodes of care and then not seeing them maybe for like a year later until maybe they had some issue like a fall or, started to have increases, loss of balance. We thought that having this consultative model where you see people over some period of time would be useful. And so part of that, is that acceptable? Is it acceptable to the therapists? Did they like it? And was it, most importantly, acceptable to the patients? And in fact, we did find this. We're going to have a separate paper related to that, the implementation of the intervention, the acceptability. But we did find that the participants liked it. There was a high retention rate. There's definitely issues with bringing people in. And, I think that the average number of sessions was between 14 and 15 out of 18. So they didn't make it to all 18 sessions. And a lot of things, as you can imagine, come up. The other thing that I think is really important to consider with this is pushing this into telehealth. And I think this kind of an intervention where there's consultations with physical therapists is really amenable to telehealth interventions. So I think that's something that we should be looking forward to the future. And we do think that this was a feasible study. It was not easy. We have the Pace-HD and Enroll-HD site principal investigators up here, and I'm glad we do, because they did all of this work. It was a lot of work for recruitment, for people to commit to being in a study for a year, especially when other studies were going on. The end of it came to the pandemic, which affected some of the study results. So it was quite challenging. As with regards to the positive signals for health-related quality of life or markers of symptom reduction, no, we did not see that. In one of our previous studies where we did a very intensive exercise intervention, so we did 3 times a week for 12 weeks of relatively high intensity exercise and strengthening, we did see changes in the modified motor score. So we did see some indication of disease kind of markers of symptom reduction. But in this study, we did not. The total motor score was relatively similar across the groups. It is something that we would like to see. I do think that the nature of this intervention wasn't intense enough. We did try to get people to increase their activity levels, move more, sit less. But I think when we're talking about the potential for exercise to be disease modifying, the potential, I think it needs to be quite intense. And I think that would be another future direction of research of looking at that. We have a couple of studies that are pointing in that direction. And certainly there's research in Parkinson's disease to indicate that. Great question. Did all of the patients have similar diets? This is definitely something that we thought about. We gave them some basic dietary information that was the same across individuals, just sort of to equalize, not within the cohort group, but there was varying diets. And I do think there's incredible potential for a combined physical activity, exercise, and dietary education program that I think would be really beneficial. Okay, I think we have time for one more question. So it's an excellent demonstration of feasibility of long-term exercise. Is there a way to translate this to help design a dosing study so that the consultant or intervention timelines might be better defined? Yes, I think we would. I think a dosing study would also be another way to go. And I think that would sort of get at this disease modifying piece of it. So I think that would be a really great idea. So you could do, sort of a high intensity versus sort of this longer term, once a month sort of consultative model. So I think that's a great point, Lisa. Okay, I think we are done. There's some other great questions, so I will try to maybe answer these in the chat. I think if there's a way that we can do that. But thank you everyone so much for your attention, and have a great rest of the conference.